I would like to thank my co-authors and my mentors. I do not have anything to disclose. I'm funded by NIH to study spine relation and dislocation after total vertebroplasty. We all know that spinal pathologies and spinal fusion can affect the pelvic tilt, and then change in the pelvic tilt can result in increased risk of dislocation. This has been shown previously in multiple different studies, including studies published by my colleagues who are actually in this meeting, Dr. Pierpont and also Dr. Vidorchik. Our question was, how much change in the sagittal pelvic tilt can also be tolerated after total vertebroplasty? A lot of our patients undergo spine surgery after we do hip replacement, so we do not have any control on their implant orientation. Our hypothesis was that less than 10 degrees of change in their sagittal pelvic tilt can result to total vertebroplasty dislocation due to prosthetic impingement. Again, we are talking about prosthetic impingement only here. We designed a MATLAB computer simulation model. We use real three-dimensional pelvis and femur for each patient. And these pelvis and femurs can be moved in any different plane. We have different implant sizes, and we can move the center of the rotation and offset and length in any direction that is needed. So here you're going to see a video. Let me see if I can start it. So here the patient is standing up. The red line that you can see here is going through the center of the neck, and the black dot represents where that line comes off at the dome of the hip. Here, first the patient moved forward, and then it came closest to the red line where the impingement, prosthetic impingement would occur. And then the patient stood up, and then that line moved forward. Here, you will see 6 dots. Each one represents one motion. You will see the pivoting and standing in anterior-superior part of the cup. And then you will see the motions that require hip flexion at the posterior inferior part of the cup. Our main predictor was sagittal pelvic tilt. We tilted it up to 45 degrees forward and backward for any different motion that we had and change it by 1 degree at a time. And the main outcome was the prosthetic impingement. We used multiple regression with ROC curve to determine how much of tilt would be tolerated easily. Other predictors in our model were anatomical cup and femoral anteversion, as well as the different femoral head sizes. And we had 3 different neck shaft angles for the stem. We had close to 1,250,000 combinations for standing and sitting, and close to 975,000 combinations for the other motions that you can see. Our results showed that the change in sagittal pelvic tilt is better tolerated in sit-to, stand, and squatting compared to the standing and pivoting. We definitely have less tolerance for pelvic retroversion, which usually is seen in flat back deformity. And this results in more dislocation in pivoting. As we already knew, larger femoral head size is going to help you a lot with the prevention of the impingement and dislocation. This table shows you some of the numbers that we have. As you can see, only 3 degrees of pelvic retroversion in a 28 millimeter head with a 127 degree neck shaft angle can result in the prosthetic impingement and dislocation. And here you will see that we have 11 degrees of tolerance when you use a 14 millimeter head. When it comes to sit to stand motion, if you use a 36 and 40 millimeter head, pretty much, and at 127 degree angle stem, you pretty much are not going to have any kind of prosthetic impingement during the motion. Of course, the tolerance is less when you use a smaller head. When it comes to squatting, you have the same finding. The best tolerance is when you use a 40 millimeter head with 127 degree angle stem, and the less tolerance is seen when you use a 28 millimeter head and 135 degree neck stem. So overall, the risk of prosthetic impingement with change in the sagittal pelvic tilt is low. Such a study that we did is not doable for bone-on-bone impingement. Bone-on-bone impingement is completely personalized, and that is something that you have to look for each person's anatomy separately. And most patients will tolerate spine surgery well without dislocation if you use larger femoral head sizes and you restore the offset and length to prevent bone impingement. Otherwise, in most cases, prosthetic impingement does not occur. Thank you.
All right, thank you very much for a very interesting talk. We have time for questions. Let me look in the Q&A here.
Yeah, maybe I can, Aidin.
Yes.
There was indeed a question about the bone-to-bone impingement, and you indicate that you cannot do that. So I thought that maybe you could include it in your model, because with statistical shape models, you could kind of have an average skeleton around the implants and then change that and then assess the sensitivity of impingement. Is that not something that you could build in your model, perhaps?
We actually had it, but I didn't put it here. You cannot use a regular bony model because each person's anatomy and the size of the bones are different. But the red line that you see, if you go back to the presentation, you will see it. There we put a red line that showed the prosthetic impingement. We had a 90% distance from the center to edge, which gives us a second line which sits in front and inside that red line. And then we considered that the line that most of the bony impingement would occur. I did not put those numbers there for you. Bone impingement generally occurs toward the end of the range of motion, not when the head is right in the center. So we came up with a conservative approach to that would give us a little bit of the bone impingement too, but that is impossible to actually give you a very good estimate when it comes to bone impingement. That's true. But then if you include the bone impingement, the numbers that you saw there, which I presented about how much tolerance you're going to have, those numbers drop by 4 or 5 degrees.
It depends, of course, on the anatomy of the patient, I guess.
Yes, exactly.
Okay, we have another question, a very quick question. How much does the included angle in the cup make a difference? So is it very sensitive to cup angle?
If you ask me, the most important variable is the combination of the cup and femur, not just the cup. One of the problems that we have is that most investigators and companies that are working in this environment for the dislocation concentrate on the cup alone. The combination of the cup and the femur is the answer, not just the cup. But yes, when you change the angles of the cup at certain degrees, you will start to see how their combination works together. So when you have too much antiversion in the cup and femur, you're putting yourself into a risk of anterior dislocation, and the opposite is true.